briefly. So Global Health Forum, as you all know, is a monthly series of seminars which really takes a topic a day. It's a topic a month, and by and large tries to pull together people from different parts of the college to discuss different aspects, originally of non-communicable diseases in particular, but now also infectious diseases as well. So there's a fairly mixed group of things, and we try to mix things up as well within the seminars. So I hope we've got a nice cross-section of different sorts of talks on different sorts of subjects. I'm going to give a very short introduction, not really even the size and nature of the problem, but really just a short introduction to introduce the different speakers and what they're going to talk about and where I think their work fits into a more general picture. And I'm going to start really with this paradox of chronic respiratory disease mortality. You look at a map of the world which shows you the mortality rates from what's put down by WHO as COPD, but we don't really know what it is. It's just what they put down. I think you could probably call it chronic respiratory disease mortality. It's probably about what it is. And what you see is rather surprising, because everybody knows that COPD is caused by smoking. And actually, if you look at the places where mortality is low, it's places like Russia and Estonia and Turkey, which are all pretty addicted to tobacco. And if you look at the places with high mortality, you find places like Ethiopia and the DRC, which have very high mortality rates, and also in South and Southeast Asia. If you compare that with what the smoking prevalence would look like, it almost looks like the mirror image. Not quite, actually. It's more or less random allocation of the two things, and I'll show you that in a slide a little bit later. So the thing that we all know about chronic respiratory disease just doesn't seem to hold for mortality rates overall. And there's a bit of a mystery as to why that should be, and a bit of a mystery about really what's going on. If we turn away from mortality and we start looking at measured obstruction of the airway, so if we look at the percentage of people who have an FEV1 FVC ratio that's less than the lower limit of normal for Caucasians, that's an important proviso, so you have to ignore the ethnicity issue here. And you plot that against the mean pack years smoked in the different bowl centers by sex. What you find is, for an epidemiologist, not a bad association between the two. It's not what you would expect in a well-conducted laboratory experiment, but you find a pretty good approximation between the two. And the red dots are the women who smoke less, and the blue dots are the men, and they smoke a bit more, and they have a bit more chronic airway obstruction. What you'll notice down here at the bottom end, where there's really very little smoking, less than 5 pack years, the prevalence of obstruction is around 5%. And that's important because the lower limit of normal is defined as the level below which you expect 5% of normal people to be. So you would expect the rate to be about 5%, even if there was no pathology and no smoking. So it would seem that really these places probably have no real discernible pathology. So the first thing that we're going to talk about is estimating smoking risks and attributable risks from smoking, and Jameen is going to talk a little bit about that. It's work in progress, but we're developing methods which we think will be rather better at getting good estimates of the attributable fractions. And after that, Andre is going to talk a little bit about tuberculosis and chronic lung disease, and how that might fit into the program as a whole, and whether it might be important. And we think of the things that we can pick up as being important causes of obstruction that seem to be fairly reproducible, a history at least of saying that they've had tuberculosis is a pretty good, is probably the next best after smoking. Now, one of the issues that's been raised is the issue about air pollution and what part that plays, because everybody knows, don't they, that air pollution causes lung disease. And this is a map from the WHO which shows the use of solid fuels for cooking. And you can see that the map looks very similar to the map that I showed you before for chronic mortality from chronic lung disease. And it has been suggested that this might be the explanation for those rather strange maps that I showed you at the beginning. I'm not going to go into that, and we're not going to talk about that very much today, that specific topic. But we do have, and that might be a topic for another seminar at another time. But we do have two talks which are related to that. One is from Louise Donnelly, who works in the laboratory and is interested in inflammatory responses. And she's going to talk about mechanisms of chronic obstructive pulmonary disease. Are they different in low-income countries? And there has been at least a suggestion that they might be. And then Frank Kelly, if he arrives in time, will talk about a program that they're doing, which is actually mostly at the moment on cardiac disease, but there has been at least talk of adding a respiratory element. So are you going to give the talk instead? Only if you have to. All right. Okay. So that's another study that's going on. So it's another interesting topic and one that's very current at the moment. Now, as I said before, there is very little relationship between cigarette consumption per head or the prevalence of cigarette consumption, number of people who smoke cigarettes, and mortality per thousand per year. That's true. It's not a positive or a negative relationship. It's just a non-relationship. But there is a relationship with poverty. And if you plot mortality rates not by cigarette consumption, but by gross national income per capita, you find this rather characteristic graph that actually, until you get to about as low as $20,000, $15,000 a year gross national income, it's a pretty evenly distributed mortality rate. As soon as you get below that, the rates shoot up. And if you look at that in relationship to one of the other measures of lung function, which is the percent of people who have a forced vital capacity that's below the lower limit of normal, again using the BOLD study, you get a very, very similar picture. Below about $15,000 a year, you get a major increase in the proportion of the population who have FVC that is below the lower limit of normal. But again, I would emphasize this is using equations that are worked out on American Caucasians. And that's controversial. And the question is, could this just be a sort of an ethnic problem? I would argue that it's not, because these are a very diverse group of ethnic communities on this side, but the line seems to be pretty sort of steady throughout. So the question is this important? And there's quite a lot of other information which we're not going to talk about, which suggests that actually if you want to know what predicts how long you're going to live, the person who invented the vital capacity, a consultant at the Brompton, but a long, long time ago, called John Hutchinson, got it about right. He called it the vital capacity because he thought that if you could measure the size of a complete lung full of air, you would be able to predict how long people were living. And that was important to him because he was an advisor to the life assurance companies, and he thought that was a good idea. So it's almost certain that when we talk about the forced vital capacity in this sense, we're talking about the total lung capacity, which is a slightly different measurement. The problem with the forced vital capacity is that it's a very difficult measurement to take well and accurately. It's very difficult, even in a research setting, to get it done well. And in a clinical setting, I would suspect that it's pretty much completely hit and miss whether people are doing it properly. And certainly our experience of doing quality assurance for groups that think that they're really good, hot stuff, at doing lung function testing, more or less there's an inverse relationship to the quality of the lung function testing. The places that think they're really good at it do really badly, and the people who are a little bit more modest and try very hard sometimes manage to get quite close. This is a big problem, and it's a problem for researchers. It also would be a problem if you wanted to introduce something that was relevant to this into practice. And what we would like to be able to measure is lung capacity, and there are sort of relatively simple ways of doing it, which might be a little bit more foolproof, but the equipment that we have to measure it is all extremely expensive and very delicate, and would not last probably beyond a month, even if it was unpacked in some of the settings that we're talking about. So the challenge is, can we make a bit of equipment? Unfortunately, we have an engineer who's interested in the problem. So the final talk of the day will be Jamie, who is going to talk about improving measurements of lung size in low-income settings. I should say, so that he doesn't feel too much on the spot, that this is very early days, so he's really going to knock some ideas about at this moment. The actual work is coming, but it's a sort of advert for what's coming. And then we'll have a panel discussion to finish things off. So I'm going to, I've overrun already, which is a bad thing for the chairman to do. So we'll move straight on, and we'll have Jamini who'll talk about estimating risks.
Good afternoon, everybody. And as my title is suggesting, I'm looking into the risk of chronic airflow obstruction due to smoking, and my main interest is low to middle income countries. Now, as Peter said, showed the slide where it shows the prevalence of smoking is varying across the world, and then the prevalence of chronic lung diseases were varying across the world. We saw the same sort of result in the BOLD study. There's only a few centers there, but the prevalence of airflow obstruction is varying across the countries in the BOLD study. At the same time, on the other hand, apart from smoking, other risk factors for the chronic airflow obstructions are biomass exposure or occupational exposure or pollution, and obviously those exposure will be varying across the centers as well. For example, effect of biomass would be different in England than in any sub-Saharan countries or Asian countries. So then the question is that we need to look at some sort of measure which tells us that how much of the chronic airflow obstruction is due to smoking in all these centers. So there are different measures in the literature you can find, so for example, odds ratio, or risk difference. But those measures are not as easy as to interpret, or they're not showing the effect at population level. So there is one measure which is called population attributable fraction, which is represent the fraction of the disease that could be preventable if we were able to eliminate that exposure from the exposed population. In other words, you can look at the PAF as the ratio of risk in the population attributable to the exposure and to the risk in the population. So this concept, if we take that concept to the formula, we can show that the population attributable fraction is the function of the proportion of the cases exposed to the risk factor and the risk ratio or risk rate of the disease due to that exposure in that particular population. So there are some problems in estimating the population attributable fraction. So basically, if we, as earlier slide showed, that it depends on the risk ratio. If you don't get the adequate estimate of risk ratio, then you're going to get the estimate of PAF, which is not correct. That happens especially in the presence of confounding and when you don't take account of confounding factors. And then there is another problem arise where you have a study like BOLD study where there are multiple centers in the study, and obviously, as we talked about earlier, the exposure to any risk factor will be different. So it will be varying across the studies. So when there is no confounding or no effect modification, risk ratio can be generalizable. But when it comes to the estimation of PAF, it locally depends on exposure to any of the risk factor we are interested locally, and the local prevalence of exposure as well. And in that case, if we, due to sometimes when the sample size is small, or relative risk is small, or prevalence of exposure is small, in that case, the confidence interval for risk ratio and the exposure is quite wide, and that reflects in the estimation of PAF, and we get the very broad confidence interval. And as we know in epidemiological study, it is important to have a precision which gives us some sort of confidence and that precision. So what generally people do to get those odds ratio, risk ratio? So in general, people use logistic regression and get odds ratio for the exposure and use as the proxy of risk ratio or relative risk. It is common method when you have your disease is rare, but if there is the disease is common, that is not valid method to use, which is when disease is common, and if you use odds ratio instead of risk ratio, it wouldn't be the good estimate for relative risk. And it could be misleading when there is a stratification applied, because you might not be able to even yield the odds ratio. So some people do use correction factor to improve that odds ratio, and they can use, but when the confounding exists, you cannot, is not a very good estimation again. So there is another way to get the proper risk ratio, which is using log binomial regression model, which gives you the risk ratio, and it is a valid estimate for the risk ratio. Not only that, in the presence of confounding, you can achieve that as well. But there is a difficulty in frequencies method that when you try to derive the relative risk using log binomial model, sometimes the model doesn't converge, and hence you're not able to get the risk ratio from the log binomial regression for some centers. So, and how do people come? There can be alternative strategies to estimate that relative risk. So, for example, you can just take the local estimate. You can do that, but as I said earlier, that when the sample size is small or exposure of risk is not enough, then even though it is the most direct estimate you can get, it will give you the wide confidence interval, and it wouldn't be the meaningful. So, our second way you can do is you can take the mean of it. But when you're taking the mean of all risk ratio across the centers, the confidence interval can be narrower, and it is reasonable if there is not too much heterogeneity. But it doesn't allow to the prevalence, which is varying across the centers. You're not taking the variability in the relative risk. So we're proposing the Bayesian method, where we use both local information and information on the distribution of estimates from different sites. So within the study, but different sites, and which allows our estimate to much narrower confidence. Not only that, but you can also use any existing prior information if it's available. To do that, we use the Bayesian approach and hierarchical model specification, where we are allowing risk ratio to vary from center to center. In other words, risk ratio is borrowing information from the other centers. And not only that, but we can achieve a local population attributable fraction from the sample. Only criticism for that is it can be sometimes computationally intensive. And how we're going to test our method. So as far as we know, there is only one method called PANAF suites of command, which is implemented by Roger Newston in Stata, which gives the path with confidence interval. And as we know that the confidence interval is more important apart from point estimation of the path. And because the variance of path is not easy to calculate, there are so many methods in literature suggested, but there is nothing implemented into the statistical program so people can use it. And we're going to compare our point estimation, which we derived using the Bayesian framework, and compare those in the basis of the confidence interval. So for the empirical example, I used the data from Bowles study for the 27 centers. And first thing first, as if we look at the prevalence of smoking across the Bowles centers, it varies. Though the confidence interval for some of the centers, they are pretty narrow, but the variation is quite high. And the countries in red are the low to middle income countries, where you can see that the prevalence of smoking is much lesser than compared to higher income countries. So there is a variation of this prevalence of smoking. Then if you look at the effect of smoking across the Bowles center, so they do vary, but if you look at the overall effect for the smoking, which has a very tight confidence interval, and there is no heterogeneity on that. So in absence of heterogeneity is allowing us to borrow information, because basically we assume that we're not saying that the risk ratio is same across the centers, but they are coming from same underlying distribution. That's the assumption we're working on it. And when we see the results, so as we were expecting, the path varies from country to country. But another thing to notice is places like Pune, Srinagar, or South Indonesia, where the lower confidence limits were negative. By borrowing information from the other centers, we managed to get the more precise estimation, and almost every center has a more precise confidence interval than compared to the classical methods of VRF. So blue dots are in classical method, and reds are using from the Bayesian approach. And when is the negative confidence interval, it's very difficult to say that how much actual effect is due to smoking, and we can overcome that problem by using the Bayesian approach. On the other hand, if we look at the prevalence of obstruction, which is attributable to smoking and non-smoking causes by centers, and we have looked at few centers only at this moment, where we can see that the non-smoking and smoking prevalence on the left-hand side of the graph, they are pretty much similar, whether you are exposed to smoking or not. And even with the where the smoking is quite low and prevalence is quite low as well, even there, the non-smoking COPD is not too much. So finally, we can say that the Bayesian method gives similar but more precise estimate of the local population attributable fraction due to smoking. We still need to optimize the definition of exposure, because at the moment we have used the smoking as a just binary variable, whether you are a smoker or non-smoker. And we still need to optimize the model that adjusted for other confounding as well. And our future plan is to calculate the path for other risk factors as well. And then if the model fits well, then we're going to create a web-based application, for example, Shiny by RStudio, and then people can use those methods to estimate their population attributable fraction for any of the risk factors they are interested. Okay? So they are varying, but they are not, because in this slide, if you look at they are different within the scientists, but they are not that different that you should concern about that. And if you look at the I-square value, which tells you that there is hardly any heterogeneity, and that p-value. So based on that, they are different, but not as different. So basically, the effect of smoking on each center is more or less similar.
That's telling you that they all come from the same distribution. So if they all had actually baseline same rate just by sampling. That's what you'll see, not seeing anything other than just.
When you say smoking, do you mean the same thing in all the senses?
Yes, it is a same question based on the same information, is only based on cigarette, and it's the same question we have asked for all the centers, whether you are a smoker or non-smoker.
Okay, so the next about Andre, and he'll talk a little bit about TB, which is the other side of things.
Hello. Like Peter said, my talk will be on tuberculosis and chronic lung disease. But as you know, this includes so many different diseases that I won't be able to talk about all of them. I'll just focus on COPD, which is a chronic lung disease of obstructive type and reversible. COPD is more common in adults over the age of 40. It's more common in men than women, but this is changing. And this is changing basically because smoking is increasing among women. We know that, as Peter also mentioned in the start of this forum, that smoking is a main risk factor. And he also mentioned that according to GBD, COPD mortality is a leading cause of mortality. COPD is a leading cause of mortality, and that this mortality is higher in low and middle income countries. And you can see from this map, it's a different map from what Peter showed you before, but it's basically saying the same thing. We have higher COPD mortality in these countries. But if you look at the prevalence of smoking worldwide, we see that there's no overlap, or almost no overlap, between COPD mortality and smoking prevalence. So if this is true, if there's this discrepancy, what is explaining the high COPD mortality? Of course, there might be different things related to what GBD considers to be COPD or not, but some people argue that what explains higher levels or higher mortality of COPD in low-income countries is outdoor air pollution. We know that countries like India and China have very high levels of pollution, so this might be an explanation for that. Or it might be high prevalence of biomass use for cooking and heating purposes. We also know that in most of those countries, biomass use is widespread. Could be that there's differences in terms of occupation. Could be that there's differences in terms of diet. Early life exposures might differ between those countries. Or it might be that there's something else like microorganisms or infectious disease that can have a say in this dispute. If we look at the world map, but in terms of TB incidence, we see that kind of overlaps. We see that in low and middle income countries, the incidence of TB is higher as it is COPD mortality. It's also true that if you remember, Peter showed a map for biomass use, and there's also this overlap. So we don't know, just by looking at the maps, whether there's a true association or not between one exposure and an outcome. So the question here is COPD associated with TB? To assess this association, I've used data from the BOLD study, or the Burden of Lung Disease study, which is a population-based study with sites in several continents. You can see them represented by these blue dots. This is a representative sample of the population over 40 years old in these sites. And the study gathers data from more than 20,000 participants with good spirometry data. To identify people with TB, we used a question, and only one question from the main questionnaire of the BOLD study, And this was as a doctor or other healthcare provider ever told you that you have tuberculosis. Of course, there are limitations regarding using exposure assessment just based on this question. But remember, this is a population-based study. It's not a clinical study, so we're not talking about doing, for example, X-rays in everybody. It would be very expensive in this case. The outcome in this case is not COPD. It's not doctor-diagnosed COPD. It is chronic airflow obstruction, which is the main characteristic of COPD, and is easily measured using spirometry. The results I'll show you are based on data from 22 sites, gathering data from almost 18,000 people. So here you have a forest plot showing the main results of this analysis. For those who are not aware of who don't know a forest plot, and this is the first time, you'll see that you have these squares. These squares represent the effect estimate for each of the sites represented here. And the bigger the square, the larger the weight of each site in the analysis. And the horizontal lines crossing each square represent the confidence interval for each site. Here you have on the top of the slides represented the sites from the low and middle income countries, and at the bottom you have high income countries represented. So if you look at the overall effects of TB on chronic airflow obstruction, you see that people who have had TB in the past are 2.5 times more likely to have chronic airflow obstruction than people who have not had TB. And this is adjusted for age, sex, BMI, and pack years of smoking, so it's independent of smoking. If you look now at the overall for the low and middle income countries, you see that the risk can be even higher than 2.5, it can be around 3. If you look at the high income countries, it's about 2. Okay, there's some overlap between the confidence intervals of those two estimates, so they're probably not significantly different. But there is this suggestion of a higher risk of TB in those countries. And this is basically a summary of what I've just said. A history of TB associated with chronic airflow obstruction. This is independent of smoking history. And it seems that the association is stronger in countries where the GNI is lower. Saying this, we still don't know a lot of things. We don't know what are the biological mechanisms underlying this association. There's some evidence suggesting that TB causes irreversible changes in the lungs, in the airways, that will make airflow, that will limit airflow. And there are evidence showing that a person is treated for TB, but there will be still some mycobacteria in the macrophages of the lungs. And somehow they will be dysregulated, and there will be still inducing some inflammation in the lungs. This is not well understood, but that has been put forward as an explanation for the association between TB and airflow obstruction. And also, we don't know whether TB is interacting with other risk factors and increasing or decreasing the risk of chronic airflow obstruction. So saying this, I just want to acknowledge the study participants, investigators, and steering committee, and all the funders. And this was very brief, but I think that I hope I made clear that there's an association between TB and chronic airflow obstruction that is independent of smoking. Thanks. You're referring to Lexington in Kentucky. Well, all of these are also dependent in a way, also in the prevalence of the disease of TB in this case. And we don't have many cases of TB in the U.S., at least in that part of the U.S. And so it's also a reason for not seeing a very narrow confidence interval. Yeah, maybe. Sorry?
I think you were suggesting that if you had TB, you were more likely to get obstruction.
Mhm. Well, it's true, this is a cross-sectional study, so you're not sure whether TB came first or not, just by looking at the data, but we asked people if they had TB in the past. And most of them will be sure that they had TB in the past. And can we be sure that they were not limited in terms of airflow in the past? Not totally sure, but it's unlikely that they were.
Do you think they would?
Maybe.
But maybe that they have a common, there is some common.
You're saying that these people would be predisposed to, but not necessarily that they would be, they would not be with COPD from the start of their life. Yeah.
Overall, I probably missed it. What proportion of the
It's difficult to remember now the numbers for all these sites, but I think that the prevalence of TB vary between 6 to, well, about 1% to 10% during the sites.
It's a small number. So, Peter, do you think? Are you surprised? I mean, my thought was that reduced volumes.
in what regard?
Well, if you see a scarred TB lung, you would think that
If you like, they may have different occupations, like that, you know.
5% of the population
Population.
does something.
Yeah.
A rather peculiar group compared to the everybody else. I mean, just adds an extra layer of complexity. On the same maybe. Frank's going to talk about it.
Afternoon, everyone. Peter was keen that I tell you about a study which is just beginning in Beijing, which will run for 4 years. With the acronym ERLIS, which we had to squeeze the title into producing, but it's the effects of air pollution and cardiopulmonary disease in urban and peri-urban residents in Beijing. And this is funded under the Newton program, which probably aware of, which is where the UK government's putting a lot of its overseas aid money into medical research, working with a number of key countries, and China was one of them, and air pollution was the focus there. So just to remind you that China has got serious air pollution problems. This is a typical picture in central Beijing. Many times a year, happens for 4 or 5 days at a time, and the weather pattern changes, and clean air comes in, and it may rain, and there's blue skies for a few days, and then it slowly deteriorates to this sort of environment again. And one of the reasons for this is really just the very, very rapid industrialization and gentrification, really, of the population. This is one of my favorite slides of sort of one of the roads coming in to Beijing. I think there's 46 different lanes there coming up to this toll booth. So you can just imagine the emissions that are associated with all those vehicles and that congestion. But think about that in central Beijing. Outside Beijing, in the rural areas, of course, as Louise has been telling us, in India, can't really see it very well here, but this is inside a home. It's a semi-open fire here. There's a big cooking urn in the middle there, and there's lots of smoke and produced in that very enclosed environment. So you may have people even within the same city which are being exposed to different combinations of different sources of PM pollution. And that's really what this study is focusing on, and the potential health effects of those different sources. So the objectives are as follows: to establish 2 panels of subjects, 120 individuals in each panel. One is in central Beijing, close to PKU, Peking University. That's the urban panel. And then the second one is the peri-urban panel, and that's being sourced from the Intermap cohort, which is outside Beijing. I'll show you a map in a minute, where one of the arms of the Intermap, the ongoing Intermap study is. The difference about the study, and one of the reasons maybe we got funded to do it, was we are using personal air pollution monitors to assess participants' exposure to a range of sizes of PM and different gases, combustion gases. And also we will be obtaining chemical composition of the PM to help us understand how it will differ between the inner and the outer city, and then again eventually maybe linking that with some of the health outcomes. We're going to be assessing cardiopulmonary function in the 2 panels, and we're going to collect a range of biosamples, including breath, condensate, blood and urine for analysis. And we're going to be subsequently assessing any association between our measurements, our personal measurements of air pollution exposure, and these cardiopulmonary measures. Just to focus in on the study areas, this is central Beijing, and if you're familiar with the city, you'll know that it's got a ring road structure. That's the 2nd ring road there, that's the 5th ring road there. So our first urban cohort is close to Peking University. It's located 11 miles away from, this is the Met Tower. This is an incredible research facility which the Chinese have. It's a 300-meter tower in the middle of the city, which is just packed full of every sort of air pollution monitoring and meteorological monitoring equipment you could wish for. So that's going to give us sort of daily measurements of pollution in that area, and I said our cohort is just 11 kilometres. The rural cohort, or the peri-urban cohort, is out in a place called Pinghu, which is where, as I say, one of the Intermap arms are. And that is a very different environment. It's a village-based environment outside the city. And we're going to set up equivalent monitoring there, which will reflect a lot of what we have here in Central, as well as the personal monitoring for all the participants. So the personal monitor is this little beast here. It's produced by colleagues in the chemistry department at Cambridge, Rod Jones and his team. And it really is, if you know anything about sensor technology, this is, in our estimation, the best thing that's available at the moment. It's got a series of electrochemical sensors here for the gases, and it's got a particle measurement component down here, which uses a laser to basically measure particles and then put them into these 3 bins. That's the various pollutants and particles which it measures. It's got a 20-hour battery life, and the idea is the individual will carry this around with them all as they move about during the day. It can either be strapped onto a belt or carried on a shoulder or even put in a backpack. And then when they come back, if they've been outside their home, they come back in the evening, they just put it into this cradle, so it's a bit like a mobile phone. It recharges itself overnight and at the same time sends us the data back for analysis. Give you some idea about how good it is. This is some data which has been compared against a central monitoring site, a government site in Beijing. So you can see the red trace is the personal air quality monitor, the PAM, and the dotted line there is the reference instrument. And you've got CO at the top, NO here, and PM2. Gases are very good, the tracking. This is, I must admit, this is some of the best data, of course, we've got. I'm showing you that just to convince you that this is, good. This is a good way of doing it. Personally, we did run into problems in January whenever the temperature fell down to, I think it was -8 overnight, and if the homes, when the instruments were out on the reference site, obviously no heating, if the temperature fell, then we did get a lot less agreement with the personal monitors. But we assume that's not going to be a problem because these things should be inside people's homes during that the overnight. Particulate matter is not as good, but it's reasonably reflective of what the reference monitors are telling us. So that should give us, everybody will have this for a week during their intensive monitoring period. That should give us a pretty good estimation of personal exposure, which we can then compare against whatever the reference monitors are nearby. What we're going to derive from this data is we're going to derive an inhaled dose, because we're going to know the accelerometer within the kit as well, so we're going to know the activity intensity. We've got the particulate and gaseous pollution measurement, so we can calculate dose. We'll know from a diary they keep, and also some smartphone apps which will be on phones, which they'll have. Will know what they're up to most of the time, and also when they're traveling, then they will keep a, not when they're traveling, but at the end of the day they will give us a brief update on what they have been doing during that day at different times. This is the study in one slide. We've got a lot of personal monitoring data. We've got a lot of other exposure data, which is either from online instruments or offline instruments, i.e. they'll be collected on filters and they'll be analysed later on in the study. Over here on the measurement side for the individuals, we're going to be looking at cardiovascular and respiratory, we're collecting cardiovascular and respiratory data. Yes, purpose of this meeting, right, we're going to be measuring lung function in the clinic when in A-3 when they're picking up their air pollution monitor and filling in the initial questionnaire. We'll then come back at day 0 where we'll do these lung function tests and measurements on them. Go away about their normal business for a week, and then they'll come back at the end of that week and we'll repeat everything again. So we'll have repeated measures over a week for this. That's the schedule. The first time we're going to do the field work is in November this year, so that's what we're setting up for at the moment. We've got a team out in the field where they're sort of learning how to to use all this equipment. We're updating the rural site with all the air quality monitoring data. So we're going to work intensely across November. This is the plan, to get through the 240 subjects at 120 at each location. And then we're going to go back again in the spring/summer in June 2017. For those of you who are not familiar, it gets pretty cold in November in Beijing, and on the 16th of November the government switches on the heating system in the whole city. So it's a overnight change from no heating to heating. So that's why we're sort of picking this month, and we'll have 2 weeks either side of that, which may give us, you know, some interesting information. That's the UK team. That's the China team. The interesting thing is this isn't the UK going out doing work in China. We're working in partnership with these excellent scientists who are already doing a lot of very good work in Beijing, but we're bringing something new to the party, as it were, with the personal monitoring. And the other thing just to appreciate is that what I've been telling you about is really in this box here in the middle. It's a 4-themed program of work. We're theme 3, the health component, but in themes 1 and 2 there are lots of atmospheric scientists who work for NERC, either in university departments around the country, in Manchester and York and Leeds and Edinburgh, and they will be doing all the very complicated atmospheric science and modelling of that, which will be important information which we would. Whole thing is meant to flow through down into theme 4, which is an interventions and solutions theme, which I've said, I think previously, that I think this is very ambitious because there's a lot to get through here, a lot of information to churn out and to understand before we can really come up with those interventions should be. But the idea would be that that would then recommend further work down the line. Thank you.
That's excellent. Any questions? Yes.
Well, and thanks for that. With the personal air quality monitors, I was just you know, because people who start using them.
Yeah, so very good question. They're a bit smaller than that. They're about that height and that width, and they're in fact they're lighter than a bottle of water. So they're just, I think, over 1 kilogram. So the idea is that if people are at their homes, they'll have them nearby, and it's only whenever they're in transit, as it were, they'll wear it on their person. Compliance, we've been actually using them in the UK in a COPD study, and we have really, really good compliance with them. We've had some people have had them for 6 months now, and I don't know what it is, but I think they think about them as a sort of it's either a pet or it's their guardian, but they really the data that we're getting back seems to link up very well with the questionnaire and the apps information that we're getting from them. So like anything, it won't be perfect, but I think we've managed to bring down the weight a lot by using these electrochemical sensors. So and I think the next, if you're interested in this sort of thing, I would think in 2 years' time it'll probably be half that size. So it's heading in the right direction.
Where are they being made?
In Cambridge, just outside Cambridge.
Of course.
Do you know Rod Jones?
Oh, it's Mortality.
Yeah. He's not making them, but he's helped develop them, and a company makes them.
Sounds like a fascinating project. How are you selecting your subjects?
So they're existing cohorts, and they're actually both cohorts. No, sorry. The Intermat cohort has already been sampled earlier this year, the whole cohort. So we will be writing, or the local investigators will be contacting, I think it's 300 initially from each of those cohorts, to ask them to come back and participate in this additional arm of the study. And it will really be, apparently in the rural site, there's a sort of elder that looks after all the communications with the cohort which lives in the surrounding countryside. At PKU, I think a lot of the people involved in that cohort have some association with the university, and again there'll be a subgroup of them contacted and screened.
So a lot of your findings are going to relate to the activity.
They're very similar cohorts in respect of age. So they're currently between, I think it's 55 and 70 something. So they're an elderly cohort. It was a cardiovascular. They were both cardiovascular-based cohorts to begin with. So they recruited post 40 age, I think, when they were initially set up. The hypothesis would be that we're initially looking for the responses to the exposure, and this is through using diagnostic screening of the blood and urine. So we're looking at new signals to that, and looking to see whether there are differences maybe between the peri-urban and the urban populations. And we're expecting to see a lot of variation in exposure because of the locations and because we're doing it in 2 seasons. And then, of course, ultimately we're looking, of course, for any markers of disease which we can link well, and if we can then see if there's any overlap between exposure. Oh, well, no, there'll be a whole set of chemical signatures in urine and blood. The functional markers of the lung will, and the CIMT measurements, etc. Those will be additionally put into the model. But whether, how we are going to use those is not clear yet until I think we get into the analytical stage. Apparently we've been doing we just sent the equipment out and we've been doing some CIMT measurements. Multiple plaques in respiratory function, one of the reasons it came along was if you've got any ideas on how we should, or what we should be doing, how we should be doing it, then we're at the planning stage now, so everything's open for change. Hopefully none.
Nicely to the next talk. And if Frank,
I'll be listening.
If Frank is talking about a subject that is only just been planned, or it sounds now half planned, Jamie hasn't even got to the planning stage, so it's a little unfair to ask him to talk. But
Well,
gamely said yes.
I gamely said yes on the caveat that I shan't give any answers. Okay. Yeah, so I guess really I'm not giving you any answers in this talk. It's really to sort of describe our design approach to addressing this problem. Okay, so improving measurement of lung size in low-income settings. So I'm a lecturer in design engineering human factors at the new Dyson School of Design Engineering here at Imperial. We opened last September. to our first cohort of undergraduate students. And really, we have a mantra as a school about what we sort of define design engineering as. So design engineering is the fusion of design thinking, engineering thinking and practice within a culture of innovation and enterprise. Now, there are a lot of terms there, so we'll break that down. So design thinking, I guess this is where my background sits really. This is about how, as designers, we start to address a problem. So how do we start to define that problem, start to brainstorm potential solutions, test them, refine them, and ultimately come up with an actual product, service or experience at the end of it. And on top of that, because it's design engineering, we've got the engineering thinking and practice. So this is about actually understanding material properties, mechanical properties that exist within a design context to allow you to formulate the best, most robust design solution. And innovation and enterprise, we're very keen to be pushing the boundaries on sort of product development, service development and experience, and hopefully engage them, in spin-out companies, things of that nature. So if you want to read around design engineering, engineering design, you hear the terms, they're interchangeable, fundamentally mean the same thing. And really it's just to get across that there's a lot of the application of mathematics in the discipline. Okay, that's a key component. So when we present this to undergraduate students or potential undergraduate students, the only requirement they actually have is a maths A-level or equivalent. So maths fundamentally underpins what we do. So some examples of kind of work, my work and also some work that's been going on in the school is we've had projects that have produced this concrete canvas. So this is rollable canvas that can be used in disaster zones. So that can instantly lay down roads, for example, divert water. We've had, this is Peter Childs, who's head of school. He, along with some colleagues, designed Qbot, which is one of his businesses. So this is a robot that you put into cavity spaces in buildings, and it releases insulating foam, so it avoids having to rip up floorboards, things like that, so it reduces costs, improves insulation. We've had other projects that have produced conductive paint for various applications. Some of my work's been in automotive sector, where I worked to look at improving the experience of driving a vehicle through automotive sound quality. But really, the thing to get across here is that there's no such thing as an engineering design that doesn't involve people. Okay, so people is one thing that we always need to consider in a design, and that's where kind of my expertise comes in. So my background in human factors is essential for good system and product design, because we start to understand the user, the context in which the user sits, and how that can inform design, so we design a robust system. Okay. So I should say now that predominantly my research is applied in healthcare. So I look at, I'll give you an example in a minute of working with the infection prevention control team up at Coventry, University Hospital Coventry, looking at improving their process for hand hygiene measurement, so ultimately reducing hospital-acquired infections. But some definitions first: human factors, ergonomics. It's the theoretical and fundamental understanding of human behaviour and performance in a socio-technical system. So this is a key term that kind of underpins my work, philosophy, if you like. Socio-technical system. This is where we've got an element of a human, a technical component, and how they interact, and how we can optimise that interaction through product design, the actual service in which it sits, etc. And there have been various updates of these definitions, so again concentrating on its systems-orientated approach. And if we want to try and visualise a system and factors that we might like to consider in the system design, we can look to a nice model that Dan Jenkins produced earlier in the year, where ultimately we're interested in system performance. But around that, we've got some key concepts that we need to start to consider. So in healthcare, one of the major considerations is safety. So if we start to think about when we're appraising a system, start to design it, what are the number of possible errors that might be produced? What's the probability of those errors? How can we start to mitigate unsafe acts in sort of human behaviour? And then we get on to things like the more subjective side of design, which is things like satisfaction. How can we ensure operator satisfaction, client satisfaction, and ultimately the other stakeholders that we need to accommodate in a design? So it could be patients, for example. And then we might also like to improve flexibility. So if we're creating kind of like a modular design of a product, how can we introduce it to have various functions rather than just a single function at any one time? So this is kind of how we go about work. So although I can't give you any answers, what I'm going to move on to is sort of the application of these sort of design thinking approaches to the point in time. So this is one approach to sort of starting to unpick a system. So this is a morphological matrix. So morphological analysis is a tool that was developed by engineers to start to, when they come up to design a product or an engineering system, you think about what functions that system's got to have and what methods can be used to achieve that function. So here we applied this to hand hygiene in healthcare. So we looked at the mode of data collection, the measurement metric, the feedback timing display, etc., etc. And then we started to map out methods that the hospital that I was working with could use to fulfill these functions. So it could be electronic surveillance, it could be a manual audit system, it could be a manual electronic audit system. And it allowed us to kind of map out where they are in their current state, but then also look at how we could start to improve that system. So what would happen if we used electronic surveillance? What other opportunities would that give in the system design? And that's how we can start to approach this problem of thinking about how we can measure lung function in a low-income country. We need to start to think about the context and the user. Okay, so we need to start to think about gathering observations around the context, identify who the stakeholders are we need to engage with, and then get them involved in the design. Okay, so another part of my work is in participatory design, which is creating methods to involve users, the end users, in the actual design process. So I wouldn't sit there and do that myself. I do that in a co-creating type of way. And then work through prototyping through to mock-ups using low fidelity and high fidelity mock-ups. I'll skip that slide. So moving on to the actual point in hand. So this is design engineering in a low-income setting. Okay, so earlier in the year I was fortunate enough to supervise our master's students doing a project in Cape Town. So this is one of the townships, Kailesha, in Cape Town, and it was called Design at the Base of the Pyramid, the economic pyramid that was. And it was really working with local entrepreneurs to develop their businesses in a more sustainable fashion. Okay, and really why I've put this slide up is that it really showed the value in engaging with the user from the word go. So some of the design solutions were working with a furniture manufacturer who made, a furniture maker who made a really standardised table. It was create a new design for an aesthetically pleasing chair in a modular design that was easy to make, was created, and those were given to him as, I guess, the sustainable solution. And other solutions existed where it was about getting the entrepreneur to actually understand the context much more, understand their stakeholders, etc., and how he could do that. So this was a board game that he could play. So these are some design solutions in low-income settings where it's addressing a real need. So if we're thinking about COPD, measurement. We can think about the requirements, that it's got to be very cheap to buy and run, require minimal maintenance. It's obviously got to provide standardized readouts and metrics, easily cleaned and sanitized, and be kept and be easy to use by both the operator and the patient. Okay. So if we go back and start to think about actually what does this look like if we're developing this lung volume system, what do we actually need to start to consider here? So this is the kind of like an adapted version of Jenkins' model, where what I've done is I've started to think through. So, okay, so we've got the safety issue again. We've got the probable errors that we might need to think about. The defaults in design. So how can we ensure that the modularity in the design prevents error when connecting the device? And that leads through to the context. So how do we know what the infrastructure expectation is in these low-income settings? And how can we create the device to accommodate the various different settings that it might exist within? And then we've got effectiveness, efficiency, satisfaction, but we've also added mechanical properties here. So we need to think about what it is we actually need to do to actually deliver the product. So we might start to think about considerations of rotating flow, airflow when we're actually designing the device, the various mechanisms, fastenings that we're going to use. They need to be really simple to be fixed. Also the material properties, how can it provide a robust fixture, but also allow it to be cleaned reliably, and tolerancing and reliability of the design. So if it's used multiple times, how can we ensure that there's no failure rates within that system? And device integration. So this is where if there's an oxygen tank, how can we ensure that those devices in various settings are the same, the fixtures are going to be the same. So these are the types of considerations that we need to start to think about. So in a way, these aren't answers. This is the approach to design that we take. So rather than just going down and thinking, okay, how are we going to design this at a technical level? If we broaden it out now, we know that we can get these other factors right, which is going to help us deliver a much more reliable design solution, an effective design solution for measurement. So that's it. So no answers, but we're getting there. Thank you.
Yes. Now you're on the hook. I can tell you all the problems that you're going to have. We'll deal with that later. But yeah, no, that's very good. And I think it is true. So the machines that we know that are portable that can do this. Hope is that we can produce something that's easy. And also be reliable.
I know you need a very well-trained.
Well, the problem basically is that first of all, are various things that you can check. there are some things which is probably not yes.
But I think really defined in a rather crude way, a conventional way, is rather similar. Globally, and probably within this country and many other countries, we see quite a strong association between COPD and
That's the issue. That's the issue. You see, when you say most of what we know died of, who knows? low FVC has more or less the same. Both contribute about equal amounts. Also, it will depend on the country because you can see some might say, and a lot of people argue that the low FVC in low-income countries is irrelevant. Which is what a lot of people. You would say that the normal values. What you find instead, interestingly, in America at least, is so it's quite possible that it's also true. Both things are important. What these people are dying of, I don't know, but I suspect, looking at the pattern, that a lot of them are dying with whatever it is that gives you a low. They are, it's something that's much more. So, your first question, my view about that is that if relative risks are great on the so wherever we look, one of the things that actually tells me that we come seem to have got the thing about right. If that's the case, actually all you need to know for those circumstances, you can probably get that from the statistics. Probably do what it's much more difficult to do. Very well. I think by and large the idea of getting a global estimate is probably much more difficult, except TB studies that bit more. Difficult in that. ratio, obviously, we expect to decline because that's the FVC, gut feeling, that it's that's probably something. The reason I say that is that most of the data, David Barker was always a bit sort of, he always really wanted was the early sort of death rates from pneumonia.
you'll be doing that